Good morning, good afternoon, and good evening, everyone, from wherever you're joining us, and welcome to the fourth webinar in the Women's Health 2024 series. Today's webinar is titled Sympathetic Regulation in Human Pregnancy, featuring Dr. Chi Fu, Professor of Cardiology and Internal Medicine at the University of Texas Southwestern Medical Center in the Institute for Exercise and Environmental Medicine. Today, she will cover her research on the longitudinal changes in sympathetic neural control in normal and hypertensive pregnancy. Before we get started, we just would like to acknowledge our partners for the series, the American Physiological Society, the Society for Women's Health Research, and Scientist.com. And we'd also like to say a huge thank you and give a shout out to all of our series sponsors. None of this would be possible without them. And a special thank you and special message from today's session sponsor, Finepress Medical Systems. Finepress aims to contribute to better healthcare by providing hardware and software solutions for continuous, non-invasive blood pressure measurements. We are delighted that with this sponsorship, we can contribute to spreading important knowledge about sympathetic regulation in human pregnancy. Many Finepress customers are working in the field of sympathetic and parasympathetic regulation in research and in clinical practice. We would like to thank Dr. Chi Fu for sharing her important work, and also thank the audience for watching right now or later on demand. We hope that you enjoy the webinar. All right, and I'm Sarah McFarland from the events team here at Scientist.com, and I'm really happy to be your host for today's event. Before we welcome our speaker to the floor, I wanted to cover a few housekeeping notes to help you get the most out of your experience today. First, we'll take a look at the interactivity panel at the right of your screen with 4 tabs: chat, Q&A, polls, and handouts. This is where you'll participate in the Q&A and polls during the webinar, as well as access all webinar resources. We want this to be an interactive experience for you, so please send us your questions, thoughts, and comments using that Q&A tab, and we'll try to address as many of your questions as we can at the end of the webinar today. You can also look at the handouts tab to look at some links and documents to learn a little bit more. And lastly, if you're having any technical issues, please try refreshing your browser and ensure that you're using Google Chrome to access this event, as it is the most stable browser. If you're still having trouble after you refresh, use that private chat function to communicate with me by sending a chat to Sarah, and I can help you to troubleshoot. All right, and before we welcome Chi to the floor, we are going to run a few audience polls here. So the first poll is, how familiar are you with the relationship between sympathetic regulation in human pregnancy and non-invasive blood pressure measurements? So there's 4 options there, and they range from I'm very familiar with this concept all the way down to I'm not familiar at all with this concept. So please choose the one that is most appropriate for you. And I'll just let you know, if you do skip that poll, you can head over to the polls tab in your interactivity panel and answer the polling questions at any time throughout today's presentation. All right, and we're getting some answers rolling in here. This is fantastic. Thank you so much. And we are about to launch another poll here. And this poll is, how familiar are you with Finepress Medical Systems and their products? So again, 4 answers there, ranging from very familiar, I'm currently using one of their products, all the way down to not very familiar, and I'm simply here for scientific curiosity. So we'll see some answers rolling in there soon. Perfect. All right, thank you so much again for your feedback on these polls. And now I'm very pleased to welcome our speaker, Chi Fu, to join me, and please take it away whenever you're ready.
Thank you, Sarah, for the introduction. And I also want to thank the sponsor, Finepress, and partners for inviting me to this wonderful session. I have nothing to disclose. In humans, normal or uncomplicated pregnancy is associated with dramatic change in maternal hemodynamics, specifically cardiac output, blood volume, heart rate, and stroke volume all increase, while total peripheral resistance decreases during the entire course of pregnancy. Mean arterial pressure decreases in early pregnancy, then gradually increases in mid and late pregnancy. These changes can be detected as early as 4 weeks of gestation and reach a plateau in mid-pregnancy. It has been proposed that maternal hemodynamic change during pregnancy occur through the sympathetic neural mechanisms. However, the actual role of the sympathetic nervous system in blood pressure regulation during normotensive and hypertensive pregnancy remains largely unclear. With the microneurographic technique, we can record post-ganglionic efferent sympathetic neural discharge in humans. The signal is called muscle sympathetic nerve activity, MSNA. In this presentation, I'm going to talk about sympathetic regulation during normotensive or uncomplicated pregnancy. Specifically, I'm going to review time course of change in sympathetic activity during normal pregnancy, the impact of multiparity or repeated pregnancy on sympathetic neural control in pregnant women. I'm also going to review the impacts of maternal obesity and gestational weight gain on sympathetic activity and pregnancy outcomes. The second part of my presentation will focus on hypertensive pregnancy. And in this section, I'm going to talk about a history of preeclampsia and its impact on sympathetic neural control during subsequent pregnancy. Finally, sympathetic action potential filing patterns and neural recruitment in gestational hypertension. So first, let's look at time course of change in sympathetic regulation during normal pregnancy. We followed a group of healthy young women with normal weight before pregnancy in the mid-luteal phase of the menstrual cycle when both estrogen and progesterone levels are high. Again, we follow them during early and late pregnancy, as well as after delivery during postpartum. This slide shows MSNA recordings at resting condition from one representative participant before pregnancy, during early and late pregnancy, and after delivery. And these are longitudinal results from all participants before, during, and after pregnancy, as previously reported by our postdoc fellow, Dr. Sarah Jarvis and Dr. Yoshioki Ogata. As you can see from this slide, resting MSNA increased from pre-pregnancy to early pregnancy, and then further increased in late pregnancy and returned to the pre-pregnancy level after delivery. These results were confirmed by 2 case reports from 2 different laboratories. One was from Dr. Danville and Starbeck's lab in Canada, and the other one was from Dr. Taylor and Mansfield's lab in Australia. Taken together, these results suggest that sympathetic activation is a common feature of normal pregnancy in humans. Dr. Nisha Chakonian, together with Stenbeck and Danville's group, they showed that resting MSNA was positively correlated with volume-regulating factors such as vasopressin in pregnant women. However, there was no relationship between these 2 variables in non-pregnant women. These observations indicate that the link between vasopressin release and resting MSNA becomes stronger in pregnancy, which may contribute importantly to blood pressure regulation in healthy women during pregnancy. In our study, we found a transient decrease in resting blood pressure, either systolic pressure or diastolic pressure, in early pregnancy. Blood pressure returned to the pre-pregnancy level during late pregnancy and then decreased after delivery. Heart rate increased during late pregnancy and decreased markedly after delivery. And these results are consistent with findings from previous studies. In addition to supine resting condition, we are also very interested in sympathetic regulation during upright position. This is important because humans spend nearly 2/3 of the day upright. Responses to the upright position have implications for ambulatory blood pressure control in humans. We performed a graded upright tilt, 30 degrees for 5 minutes, and then 60 degrees for another 5 minutes. After that, we returned to the participant to the supine position for recovery. Open circle indicates pre-pregnancy. As expected, MSNA burst frequency, which is the number of bursts per minute, and burst incidence, which is the number of bursts per heartbeats, both increased progressively at 30 degree and then 60 degree tilt. And then MSNA returned to the baseline level during recovery. During early pregnancy, closed circle here, both supine and upright MSNA was significantly higher compared to pre-pregnancy. However, the change in MSNA from supine to upright was similar between pre and early pregnancy. Despite sympathetic activation, more women had presyncope during upright tilt in early pregnancy than in pre-pregnancy. This slide shows beat-by-beat finger blood pressure measured non-invasively by FenaPress and heart rate and integrated MSNA before, during, and immediately after presyncope in one woman during early pregnancy. In our study, 9% of the participants had presyncope before pregnancy, and 26 of them, the same participants, had presyncope during early pregnancy. So we wanted to know why. The first thing we looked at it was sympathetic barrier effect sensitivity, as it plays an important role in beat-by-beat dynamic blood pressure regulation. Sympathetic barrier effect sensitivity was measured during spontaneous breathing by relating MSNA to diastolic pressure. The slope of this relationship indicates barrier effect sensitivity. We found that sympathetic barrier effect sensitivity was not clearly different between pre-pregnancy black bar and early pregnancy pink bar in the supine position and at 30 degree and 60 degree upright tilt. The next thing we looked at it was sympathetic vascular transduction, which was calculated from lean forearm vascular resistance divided by resting MSNA. And we found that sympathetic vascular transduction was blunted during early pregnancy when compared to pre-pregnancy. The blunted sympathetic vascular transduction was found not only during early pregnancy, but also during late pregnancy. For instance, Dr. Stenbeck et al., they used a signal average approach method to measure sympathetic transduction into blood pressure in women during late pregnancy and also in non-pregnant women. And they found that changes in mean arterial pressure following MSNA bursts were smaller in pregnant women, white bar, compared with non-pregnant women, black bar. These results indicate that sympathetic transduction into blood pressure was smaller in late pregnancy. The measurements in Dr. Stenbeck's study was made in the resting condition. The blinded sympathetic vascular transduction was also observed during physiological stimulations, such as the cold pressor test in women during late pregnancy. As reported by Dr. Usman et al., the transduction was smaller at baseline as well as during peak cold pressor test in late pregnancy women, again open bar, compared to non-pregnant women, closed black bar. Taken together, normal or uncomplicated pregnancy is associated with reductions in sympathetic vascular transduction, which results in a dissociation of sympathetic outflow from hemodynamic outcomes, even during cold pressor-induced sympathoexcitation. Back to our study, we talked about sympathetic neural control or responses to upright tilt before pregnancy and during early pregnancy. Now, what about responses during late pregnancy? Dr. Heason from our group, she showed that during late pregnancy, blue symbols, MSNA was further increased in the supine position and also at 60-degree upright tilt. However, at 60-degree upright tilt, MSNA was not clearly different between early pink symbol and late pregnancy blue symbols here. Black symbol indicates pre-pregnancy. These results suggest a blinded MSNA response at 60-degree tilt in late pregnancy, which was due to a ceiling effect, we think. So in summary for this session, sympathetic activation occurs early during uncomplicated pregnancy, remains high throughout gestation, and returns to the pre-pregnancy level after delivery in healthy women with normal weight. Changes in sympathetic activity from supine to upright are well maintained in early pregnancy, but attenuated in late pregnancy. Syncope in women during early pregnancy is likely due to a blinded sympathetic vascular transduction rather than reduced sympathetic barorefax sensitivity. Next, the impact of multiparity. Evidence suggests that multiparity or repeated pregnancy is associated with an increased risk of cardiovascular disease in women later in life. For instance, a large epidemiological study in Swedish women showed that there was a J-shaped relationship between parity and cardiovascular disease risk. After 2 pregnancies, the risk of cardiovascular disease increases as parity increases. This relationship was confirmed by a recent study among Iranian women. The mechanisms for such a phenomenon are unknown. It is possible that women with no or very few pregnancy, they may suffer from infertility, PCOS, or other medical conditions that increase the risk of cardiovascular disease. On the other hand, we speculate that increasing parity after 2 births may result in repeated exposure to sympathetic activation, altered within pregnancy sympathetic regulation, and its related pathophysiological burden. All these are likely to increase cardiovascular disease risk in multiparous women. To verify this speculation, we combined data from 2 different laboratories, our lab in Texas and Dr. Davenport and Stenback's lab in Canada. We performed a retrospective data analysis. 10 women participated in our study twice during 2 consecutive pregnancies, the first and the second tested pregnancy. As expected, age was greater in the second tested pregnancy versus the first one, but height, weight, and gestational age was similar between these 2 pregnancies. All comparisons were adjusted for age, and we found that resting systolic and diastolic pressure were not different between the first and the second tested pregnancy. Heart rate trended higher in the second tested pregnancy compared to the first one. Resting MSNA was significantly higher in the second versus first tested pregnancy. However, sympathetic barorefact sensitivity was not different between these 2 pregnancies. These results indicate that there is altered within pregnancy sympathetic activation, which may be related to detrimental or unfavorable cardiovascular change with multiparity. So in summary, resting sympathetic activity and heart rate are greater in healthy women during the second tested pregnancy as compared to their first one. Blood pressure and sympathetic barorefact sensitivity are not significantly different between the 2 pregnancies. These results may highlight a possible role of altered within pregnancy sympathetic neurocontrol in the regulation between parity and future cardiovascular disease risk in women. And what about maternal obesity and gestational weight gain? Obesity in pregnancy is now one of the most important challenges in perinatal care. In the United States, about 50% of pregnant women are either overweight or obese. A population-based study showed that increased body mass index, BMI, has a linear correlation with the percentage of late-onset preeclampsia, indicated by a black bar, which occurs after 37 weeks of gestation. The underlying mechanisms remain largely unclear, but sympathetic overactivation may contribute. We performed a longitudinal study and measured sympathetic activity in women with obesity and those with normal weight during early and late pregnancy, as well as after delivery postpartum. All women in this study, they had the normal pregnancy, and we did not include data from women who had a complicated pregnancy in this paper. We found that women with obesity had higher MSNA at rest during late pregnancy when compared to women with normal weight. However, MSNA was not different between the two groups during early pregnancy and postpartum. Though still within a normotensive range, women with obesity had higher ambulatory weak systolic pressure compared to women with normal weight during early and late pregnancy as well as postpartum. Diastolic pressure was higher in women with obesity during early pregnancy and postpartum. Obesity is a risk factor for sleep apnea. With the use of portable device, we performed in-home sleep testing to identify pregnant women with sleep apnea. We found that among pregnant women with obesity, resting MSNA was higher in those with sleep apnea versus those without. However, this was not observed in pregnant women with normal weight. These results indicate that maternal obesity may amplify sleep apnea-induced sympathetic activation during pregnancy. What about gestational weight gain? Gestational weight gain recommended by the Institute of Medicine is based on maternal pre-pregnancy BMI. Exceed the upper limit of each range is defined as excessive gestational weight gain. Excessive gestational weight gain, indicated by the pink bar in this slide, significantly increases the risk of hypertensive disorders during pregnancy, especially in women with overweight and obesity. So we want to know if sympathetic activity contributes to weight gain-related pregnancy risk. Surprisingly, combined data from our group and Dr. Davenport's group showed that gestational weight gain did not impact resting MSNA burst frequency, burst incidence, or sympathetic bioeffect sensitivity in healthy women during late pregnancy. However, in this analysis, only 3 women were classified as obese, indicated by green circles, 1 in each group. So we looked at our data based on pre-pregnancy BMI and also gestational weight gain. We divided participants into 4 groups: normal weight women with normal gestational weight gain, normal weight women with excessive gestational weight gain, overweight women or obese women with normal gestational weight gain, and overweight or obese women with excessive gestational weight gain. As shown in this slide, the rate of complicated pregnancy increased progressively from the left to the right. So the left one is normal weight women with normal gestational weight gain. The very right is overweight obese women with excessive gestational weight gain. These are unpublished data from our group. Resting MSNA birth frequency in late pregnancy seems to be impacted by maternal obesity, but not gestational weight gain. Birth incidence was not clearly impacted by maternal obesity or gestational weight gain. Red circle indicates gestational hypertension, and yellow circle indicates preeclampsia. We found that excessive gestational weight gain was related to higher resting systolic and diastolic pressure in normal weight women, but not in women with overweight or obesity during late pregnancy. On the other hand, resting heart rate during late pregnancy was greater in women with overweight or obesity versus normal weight women, regardless of gestational weight gain. So in summary, women with obesity have greater sympathetic activity at rest during late pregnancy compared to women with normal weight. Ambulatory weak blood pressure is higher in women with obesity throughout gestation and postpartum compared to women with normal weight. Maternal obesity seems to amplify sleep apnea-induced sympathetic activation during pregnancy. Excessive gestational weight gain is associated with a profound increase in the risk for complicated pregnancy, especially among women with overweight or obesity. However, this increased pregnancy risk may not be directly related to excessive sympathetic activation. Other mechanisms, such as change in vascular function or cardiometabolic profiles, should be considered in future research. The second part of my presentation focuses on hypertensive pregnancy. First, a history of preeclampsia and its impact on sympathetic regulation during future pregnancies. A history of preeclampsia significantly increases the risk of developing hypertensive disorders again in future pregnancy. Blue bar indicates no history of preeclampsia, and white bar indicates a history of preeclampsia. As shown in this slide, having preeclampsia in one pregnancy is a strong predictor for recurrent preeclampsia in future pregnancies. We follow the women with and without a history of preeclampsia before, during, and after pregnancy. And we named these two groups the high-risk group and the low-risk group. Some participants developed gestational hypertension during the study, but none of them had preeclampsia. The rate of gestational hypertension during the study was 8% in the low-risk group, and it was 44% in the high-risk group in our study. After completion of the entire study, we regrouped the women into 3 groups. Black square indicates the low-risk normal pregnancy group. Gray square indicates the high-risk normal pregnancy group. White square indicates women who had gestational hypertension during the study. We found that throughout early and late pregnancy, as well as postpartum, MSNA was higher in women with gestational hypertension compared to high-risk women with normal pregnancy and low-risk women with normal pregnancy. Interestingly, recent studies showed that preeclampsia was not associated with augmented sympathetic activity. For instance, MSNA burst frequency, burst incidence, burst amplitude, and total activity were all similar between women with normal pregnancy and women with preeclampsia. However, plasma norepinephrine concentration was higher in women with preeclampsia compared to women with normal pregnancy. In our study, before and throughout pregnancy and postpartum, mean arterial pressure and heart rate were augmented in women with gestational hypertension. However, women with high risk, who had a previous history of preeclampsia, they also had higher mean arterial pressure and heart rate compared with low-risk women with normal pregnancy. I would like to talk briefly about the natriuretic peptide system and its interaction with the sympathetic nervous system. Specifically, I would like to talk about an enzyme called colon. Colon converts pre-MPs to active MPs. MPs, natriuretic peptides, play an important role in sodium and water excretion and vasodilation, and therefore blood pressure regulation. Colon expression can be detected in the heart and the pregnancy uterus. Colon is involved in vascular remodeling during pregnancy. Previous studies showed that plasma colon level increased during normal pregnancy versus non-pregnancy. Colon further increased in women with preeclampsia. We found that colon increased from pre-pregnancy to early pregnancy, further increased during late pregnancy, and returned to the pre-pregnancy level after delivery. The increase in colon from early to late pregnancy was the greatest in women who had gestational hypertension. We also found that change in colon from pre-pregnancy to early pregnancy was correlated with resting MSNA in early pregnancy. In addition, mean arterial pressure in late pregnancy was correlated with change in colon from early to late pregnancy. In summary, a history of preeclampsia increases the risk for hypertensive disorders during future pregnancy. Throughout pregnancy, sympathetic activity, blood pressure, and heart rate are all augmented in women who later on develop gestational hypertension. Colon plays a unique role in sympathetic regulation of blood pressure throughout normotensive and especially hypertensive pregnancy, and may represent a promising biomarker for determining women at high risk of cardiovascular complications. In the last few minutes, I would like to talk about sympathetic action potential filings in gestational hypertension. Using a novel action potential AP detection method developed by Dr. Kevin Shoemaker's group in Canada, we looked at multi-unit action potential filing patterns and neural recruitment during normotensive and hypertensive pregnancy. Action potential AP filing patterns are expressed as mean AP content per integrated burst, AP frequency, and AP incidence. Neural recruitment patterns are expressed as the number of action clusters, active clusters per integrated burst, and the number of total clusters detected. First, we looked at cross-sectional data in non-pregnant women, low risk and high risk women with normal pregnancy, and finally women with gestational hypertension. So 4 groups. And these are representative tracings of integrated MSNA and detected APs from 4 subjects in each group in the resting condition. And these are individual and mean data from all participants at rest AP content per integrated burst was augmented only in the gestational hypertension group compared to the control and low-risk normal pregnancy and high-risk normal pregnancy groups. However, AP frequency and incidence was significantly higher in both gestational hypertension group and high-risk normotensive group compared with the control group. We also found a positive correlation between blood pressure, both systolic pressure and diastolic pressure, and AP filing expressed as frequency and incidence. This graph shows AP per integrated burst in the supine position or baseline, open circles, and at 60-degree tilt, black circles, from 4 different groups. In response to upright tilt, women with gestational hypertension, they were unable to increase within burst AP filing or recruit latent subpopulations of larger sized APs, perhaps related to a ceiling effect. And these are changed from baseline to upright. The responses were not clearly different among groups. However, AP filing frequency and incidence during upright tilt were elevated in women with gestational hypertension when compared to women in the other 3 groups. Again, the responses were not different among groups. I apologize for this busy table. So this table shows AP recruitment patterns during supine baseline and 60-degree tilt in the control group, low-risk normal pregnancy group, high-risk normal pregnancy, and gestational hypertensive group. Compared to supine baseline, the number of active AP clusters per burst increased during upright tilt in controls and trended higher in low-risk normotensive pregnancy group, but no change was observed for high-risk normal pregnancy or gestational hypertension group. Compared to baseline, the total number of AP clusters detected, which indicates recruitment of previously silent subpopulation, increased during upright tilt in controls, but not in the other 3 groups, not in the pregnancy groups. However, the magnitude of response was not different among groups. Finally, we compared longitudinal data in women with normal pregnancy versus those with gestational hypertension. During pre-pregnancy, AP content per integrated burst was similar between the groups. In gestational hypertension, indicates by open square, AP content per burst increased during both early and late pregnancy, which was very different from women with normal pregnancy. Therefore, throughout the entire gestation, the mean AP content per burst was much greater in women with gestation compared with women who had normal pregnancy. The results are the same for AP frequency. So the traditional metric for MSNA burst frequency was about 70% higher in gestational hypertension than normal pregnancy. However, when we look at AP data, AP filing was nearly 250% higher. And these results indicate that AP filing patterns represent a more sensitive measures to detect or predict pregnancy-related abnormal conditions or complicated outcomes. We found that the change in AP frequency from early to late pregnancy was related directly to resting mean arterial pressure in late pregnancy. So in conclusion, normal pregnancy is associated with sympathetic activation, which occurs early, sustained throughout gestation, and returns to the pre-pregnancy level after delivery. Multiparity increases sympathetic activity to the heart and skeletal muscle in pregnant women. These results may highlight a possible role of altered within pregnancy sympathetic neuroregulation in the relationship between parity and future cardiovascular disease risk. Maternal obesity is associated with greater sympathetic activation even during normotensive pregnancy. Excessive gestational weight gain increases the risk for complicated pregnancy, especially among overweight or obese women. However, this increased risk may not be directly related to excessive sympathetic activation. Finally, sympathetic activity is augmented during early and late pregnancy in women who subsequently developed gestational hypertension, while action potential filing patterns represent a more sensitive measure to detect or predict hypertensive disorders during pregnancy. There are so many people I'd like to thank, which include, of course, postdoc fellows and staff members. I also want to thank my long-term collaborators. All of them have contributed importantly to the work I presented today. And finally, I want to thank funding sources, NIH, AHA, Henry Moore Heart Foundation, and I also want to thank the sponsors, FinaPress, and partners. Again, thank you so much for your attention, and I'm happy to answer all the questions you may have.
Okay. Well, thank you so much for that presentation. It really was fantastic. And I'm going to let you just catch your breath while I deliver some housekeeping notes here. So I just want to remind the audience to pop over to the Q&A tab. You can send any questions you have for Dr. Fu in there, and we'll try to address as many as we can. While you're furiously typing your questions for Dr. Fu, I did want to share our survey with you. If you have to leave early, please submit that survey. We really appreciate your feedback. All right, and I'm going to bring Dr. Fu back on here. Hi, welcome back.
Thank you,
Again,
Sarah.
thank you so much for that presentation. And if you're ready, we'll get started with the Q&A.
Sure.
Okay, so the first question that we have here is, in the multi-parity heart rate and blood pressure assessments, did you do pre-pregnancy changes, like the differences of heart rate and blood pressure in pre-pregnancy of the first child and then pre-pregnant of the second child?
No, unfortunately, we didn't, because I think in some of these participants, they can participate in a study when they already became pregnant. In our study, we did have early pregnancy and then late, then postpartum. I think in Dr. Davenport's study, I think they did, they had data only in late pregnancy.
Okay. All right, thank you for that. Next question here. First, a nice compliment, really nice work. In the multi-parity study, was the number of miscarriages, if any, included in the number of pregnancies? And if so, does that play a role in the effect of multi-parity on blood pressure changes?
That's a great question. In our small subset of study, when we had 10 women who had tested twice, none of them, I don't believe any of them had miscarriage. But in our large database, we had about 5% to 10%, no more than 10% of participants had miscarriage. When we counted, we didn't include the parity information there, but miscarriage clearly impact or related to cardiovascular disease late in life. And that's a great question. Mm-hmm.
Okay, great. The next question here, does fitness level have a protective effect on sympathetic activation in women with obesity?
That's a great question. I believe so. In our study, we actually excluded women who were considered very fit. As you know, especially among women with obesity, a large majority of them, they are sedentary. But, exercise training clearly would reduce. I think Dr. Davenport's study showed exercise training could reduce sympathetic reactivity in women, either overweight or obese or normal weight.
Okay, that makes sense. Another question here. In the group, you assessed changes in neurotransmitter levels with hypertensive disorders. Did you look at rates of postpartum depression as well, or rates of depression under other mental health disorders prior to pregnancy?
That's a great question. And actually, unfortunately, we did not.
Okay.
We focused more on the physiological side, but that's a very important question. And we did have a few women during postpartum, especially, they had depressive, symptoms. Maybe a handful of them even received medication treatment.
Okay.
Mm-hmm.
Okay. Another question here. Is the increase in cardiovascular disease in women with multiple children or multiparity due to the stress of caring for more children, or does it correct for the ability to afford childcare?
Yeah, that's a great question too. Again, unfortunately, we did not assess the stress level or socioeconomic conditions in our study, but these are very important factors and need to be addressed in future research.
Absolutely. Agreed. Great questions coming in. Keep sending them. Like I said earlier, if we don't get a chance to get to your question today, we will still pass them along to Dr. Fu. So you will get an answer, I promise. Another question here. So have you evaluated heart rate variability in conjunction with MSNA to determine if heart rate variability demonstrates parallel relationships with preeclampsia, as does MSNA?
Great question. Another great question. We have data, but we have not looked at heart rate variability yet. I would think they should change in the same direction as MSNA, sympathetic activation to the skeletal muscle versus sympathetic activation to the heart.
Okay. Yeah, that makes sense. Another question here is, how are you measuring overweight and obesity? Is it with BMI?
Yes, we use the safe reported pre-pregnancy BMI to separate the group and confirmed BMI calculation during early pregnancy. But we recognize using BMI to distinguish women with obesity or normal weight has limitations. Unfortunately, we cannot use DEXA or other measure. Maybe we can measure skin fold, but there are also limitations. with those measurements, but we cannot measure body composition with with DEXA, unfortunately, in pregnant women.
Okay, makes sense. Another question here. You mentioned that earlier that you used a large database for part of your study. Can you explain that a little bit further?
Maybe I didn't express correctly. When I mentioned large database, I mean the data from our group collected over the past 15, 20 years from about 300, close to 250 or 300 people, pregnant women. So it's not using epidemiological data.
Okay, that makes sense. And I did want to remind everybody, if you do have to leave early, there is a survey over there in the handouts tab. So please submit your feedback there. We really appreciate it. And if you do have questions for Dr. Fu, please submit them in that Q&A tab. We have a few people in here asking about the recording and the slides. As I mentioned earlier in the lecture, there will be a recording available and you'll get an email about that. Okay, another question here. Was the sympathetic activation control in pregnancy examined? I'm not quite sure.
Can you repeat that? The sympathetic control, well, we used microneurography to measure sympathetic activation to the skeletal muscle vasculature. We also measured plasma catecholamine levels, which is maybe an indication of systemic vascular, systemic sympathetic activation. We also measure renal adrenal hormones, which can provide some insight into renal, the kidney activation of the renal adrenal system or the kidney. I think we assessed using different methods. I hope that answered the question.
Yeah, I think so. I wasn't super sure what they meant by that, but hopefully it did. If it didn't, please send a response question in there. All right. I'm just glancing at the time here, and it looks like we are coming close to the top of the hour. So I'm going to just push everyone over to that survey again. And while you are looking at that, Dr. Fu, I really just want to thank you so much for your expertise and your time today. It really was a pleasure to have you with us, and I hope that you had fun.
Thank you so much, Sarah. I really enjoy interaction, especially with the questions. Excellent questions.
Yeah, we have some great questions. All right. And all of the ones that are coming in now, I am going to send to you to answer in your Q&A report later. So yeah, thank you again. And it really was a pleasure.
Yeah, thank you, Sarah.
All right. And I also want to thank our live audience for being here. We know you have busy schedules. So we really do appreciate you being here live, and I hope that you enjoyed your experience today. Please join us in the next event in this series on Wednesday, November 20th, which is next week, at 11 a.m. Eastern Time. You will receive a reminder email with the link to log in soon, so be sure to block it off in your calendar so that you don't miss it. As I mentioned earlier, just a quick reminder, a recording of today's webinar will be available soon, so keep an eye out for an email giving you access to that. And additionally, that survey will appear again at the end of this webinar. We really do read all of your feedback and your comments, so we appreciate your input there. You can also, in that survey, let us know what webinar topics you'd like to see in the future. And finally, as I mentioned, if you still have questions for our speaker, you can submit them in the survey as well, and we'll be sure to pass them along. In closing, we hope that you enjoyed this Inside Scientific webinar sponsored by Finepress Medical Systems and produced in partnership with the American Physiological Society, and I hope that you all enjoy the rest of your day.